Okay, I will discuss regarding a case from medical six. He is a 54 years old Chinese male, have been diagnosed with schizophrenia for more than 20 years. He's under psychiatric HKL follow-up, 6-monthly follow-up, and prior to current admission, he was stable, no psychotic symptoms, able to work as a laborer. So he is on atypical antipsychotic, olanzapine, and also antidepressant, fluvoxamine. The olanzapine was started since 3 years ago, no recent increase in dose. So he came to our attention on the 17th of October 2020 when he presented with altered sensorium for 3 days. And on the day of admission, he had generalized body weakness for 1 day. His father noticed that patient unable to get up from the floor due to generalized weakness. However, no history of trauma. Father unsure regarding history of medication overdose. He has no seizure, no muscle jerk, and no extrapyramidal symptoms. Upon our assessment, his GCS was 12/15, BP borderline high with and tachycardic, and there is high-grade temperature of 38.9. At that time, he able to move all limbs with muscle power of at least 3/5. However, no muscle rigidity, and then no clinical sign of trauma. Her blood test showed leukocytosis, but only CRP only 2. There is AKI. His baseline creatinine was 72 in February this year. On presentation, it was 240 with hyperkalemia. And the creatinine kinase is 100,000. So at that moment, as patient was on neuroleptic drugs, and there is high-grade temperature with CK of 100,000, we presume he had neuroleptic malignant syndrome, and he was started on IV dantrolene stack dose and continue with bromocriptine. And in regards to his AKI, we monitor closely with low threshold to initiate dialysis. So he was admitted to HDW for close monitoring. We give a high volume hydration, and on day 2 of admission, due to refractory hyperkalemia with reducing urea output, nephrology team planned for hemodialysis support. However, upon our assessment, we noticed that patient had swelling over the right thigh and also the right leg, which was tense and tender. He unable to move his right leg and including his toes. So he was diagnosed as non-traumatic right leg compartment syndrome, urgently referred to ortho, and patient underwent urgent fasciotomy on that day. So intraoperatively, there is muscle necrosis over the posterior compartment of the right thigh, which I shown in this picture. And then also necrosis of the anterolateral aspect of the right leg, which is 2 different locations. The operation was successful and patient recovers well and underwent resuturing 4 days after the first operation. So while in ward, this is the timeline for the past 1 month when patient was admitted. He came in on the 17th. Our diagnosis initially presumed NMS with AKI secondary to rhabdomyolysis. We start on dantrolene and give hydration. However, urea output is poor, and then hyperkalemia, we initiate dialysis. And then at that time also we noticed there is compartment syndrome. So patient underwent urgent fasciotomy. And then we sent all the workup for the rhabdomyolysis. On the 3rd of November, we have myositis profile, which turned out to be anti-PL7 positive. So we diagnosed as autoimmune myositis, was started on prednisolone 16 mg daily. However, we reduced the dose as patient suspected to have a scrotal abscess. So we cut the dose to 50 milligram daily. While in ward, patient had few events happen. On the 8th, he pulled out his right IJC that we used to dialyze him. And then we reinsert the new one over the left side. And then about 10 days after that, he pulled the left IJC. And then we insert again over the right side. And then we give him dialysis support. And then the latest update regarding this patient is now he's diagnosed as anti-synthetase syndrome. Plan to start methotrexate and continue with current dose of prednisolone. So this is the result of his myositis panel. He has other anti-Jo1, ACL75, all are negative. The one that positive is anti-PR7. So now he is on day 39 of admission. Our diagnosis now is rhabdomyolysis with compartment syndrome, secondary to autoimmune myositis. And then he had acute kidney injury which require intermittent hemodialysis. This is his creatinine trend. When he admitted is around 240 and it triple in 2 days and then requires intermittent hemodialysis support. So now creatinine trend shows it rebound quickly after our dialysis support. So he still require hemodialysis. So the main issue with this patient is his psychosocial issues. This patient is single and he lives with his father. He used to work as a laborer but stopped working 6 months ago. His cognitive function, however, a bit impaired. He had in view of long duration of schizophrenia for more than 20 years, and then his education level only up to standard 6. And then in ward, we have mobility issue with this patient. He is a big size guy with estimated weight around 90 kilogram. And then due to his recent operation and deconditioning condition, he had limited movement over the bilateral lower limb. And up till now, he's still unable to transfer to chair. And he is dialysis dependent, as for now. For the family support, he lives with his father, which is 80 years old, live in apartment at 16th floor at Bandar Toraza. And financially, they only supported by his uncle. However, his uncle not live together. The uncle live at Oakland Road, work as contractor, monthly income only around 1,000 per month. He himself had 8 children, doesn't have fixed working hour, and he is the main caretaker for both patient and his father. So in the long-term plan, the uncle plan to put patient in a Rumah Kebajikan Warga Emas Sangliang at Pahang. However, still not approved yet, and then might take some time. So the other plan is to place patient at one of the nursing home in Medicare in Petaling Jaya. So we think the main issue with the problem that we start with is his psychosocial issue, mainly his financial support and poor, not so good family support. So we would like to discuss regarding this issue in our meeting.
Hello. Sorry. I think the psychosocial aspect shouldn't be a problem. I guess we have JKSP that we can refer to, and from what you presented, seems that they really need help, and we do have money. So, and if let's say he has acute kidney injury and we are waiting for the kidney to recover, that we will give up to 3 months. So I think he can do even dialysis here, because if you send the patient out to standalone dialysis center, they have to pay. So for me, we can refer to JKSP, and we try to make sure that he doesn't have to pay for the hemodialysis. That is part of the psychosocial. We do have money in JKSP, so I think he is somebody that will benefit and from JKSP. That's my input. I think Dr. Roslinda also asked me to ask few questions. Prof. Roslinda also asked me to ask few questions. You know, the first questions that Prof. We want to know is that, is this patient truly have inflammatory myositis? So Prof. Sharil is there. So we want to invite Prof. Sharil opinion whether these patients truly have inflammatory myositis.
Okay, thank you, Prof. Halim and the team. Well, initially, the diagnosis was to rule out any drug disorder that can cause myositis. But then after the drug was stopped, the CK did not come down properly. And currently, I think the CK is now only a few hundred with steroid on board. So there is a response with steroids. But again, we can't use this response as though that it is a diagnostic criteria for anything. And of course, the best diagnosis in any myositis is still tissue diagnosis. But unfortunately, when the compartment syndrome fasciotomy was done, the sample was sent, but not sure whether the histology part of the muscle and all those criteria for diagnosing myositis was actually looked at. So we are planning to call back the pathology to closely look at the muscle fibers now to determine what type of myositis it is. But by history-wise and by response of the immunosuppressant, it is probable, which is actually the least strong criteria if you talk about probable, possible, and classical. And the thing is about him, the antibody was also positive, which is associated with anti-synthetase syndrome. Now, of course, anti-synthetase syndrome has its lung pathology, and perhaps I'm not really in an accurate sense to start the patient on methotrexate. But of course, the best medication for myositis so far is still methotrexate, but then plus or minus your mycophenolate mofetil. But of course, the CK is responding, so I'm not going to start the patient on MMF just yet. We'll see how it is with methotrexate. Lung-wise, the crabs are there, but it's not that bad. It's just fine crabs and so on and so forth. And we are stopping short on pulsing the patient because of the scrotal abscess. So probably once the scrotal abscess and the septic parameters have reduced, probably I'll pulse him for the myositis per se. But again, the CK is down, so there's no urgency to even pulse the patient at this moment of time. But then if I were to ask regarding his kidneys, were there any imaging to see what's the size of the kidney and whether a biopsy is possible at this moment of time? Thank you.
Maybe Dr. Azhar or somebody from Nephro can answer. I do not know the case in details.
The kidneys, we don't perform the ultrasound KUB for this case, but the kidney, he has no previous kidney impairment before.
No,
what's the size?
yeah.
Size of the kidney?
we need to have ultrasound of the kidney to see, you know, why is it still, do we have to rule out obstructive, or I think we need to know the size of the kidney and see, I understand it's acute kidney injury, but I think we need to know the echogenicity of the kidney. And I think if it's stable, maybe we should be able, it has urine output.
The urine output is good,
it's good.
around 1,500 cc.
But I think it's a very fair questions to know whether how big is the kidney, whether kidney is biopsiable or not, you know. Normally for acute kidney injury, if there is some response in terms of, is there some response in terms of AKI, urine output is coming up, or still the same?
The urine output is improving, about 1.5 liter per day. And then the creatinine is compared to the peak, now it's hovering around 400 to 500. So
when there's some improvement in AKI, so sometimes we do not do biopsy, but if let's say we see the AKI is prolonged, we may do biopsy to see whether this rhabdo and CAS nephropathy cause by doing biopsy, we will know CAS nephropathy, and that will give us impression maybe this patient will be on long-term dialysis or will have chronic kidney disease after acute kidney injury. So what we have to do, I think we have to do ultrasound, but I don't think we need to do biopsy at this point of time because there is some improvement. Prof. Shari, did we start methotrexate? We didn't start methotrexate.
Come again, Halim?
Methotrexate kita tak start kan?
Dah start lah.
Oh, dah start lah. Okay.
Very low dose lah, 7.5 weekly.
Okay. And I think in terms of kidney we can wait. So the next question is renal recovery started to emerge now, but still stage 5 and good urine output, but we will discuss on non-recovering. But I think because it's still within 3 months, we will give patients some time, and sometimes because of rhabdo, it takes longer time. A lot of urine output doesn't mean anything. Maybe the patient has tubular defects, but I think we will see. If the creatinine managed to start at 400, we may escape dialysis, you know, so we don't have to think about long-term hemodialysis. And number 3 is that underlying psychiatric disorder, very hard to make him understand the whole situation and following commands. So I'm not sure it's not controlled. He has schizophrenia, so his schizophrenia is not controlled. Okay?
Now, no more psychotic symptoms. So the psychiatric team restarted back antipsychotic Seroquel yesterday.
Okay.
While in what he doesn't have overt psychotic symptoms.
Okay.
May I ask? Assalamualaikum. May I ask? So Prof. Shari, so this apa tu yang inflammatory myositis tu, is this a typical presentation of that disease? And then what is the long-term management for that? No?
Okay, number 1, nothing is typical in medicine now, but then in this patient, it's very difficult to assess the typicalness because of the patient's background of psychiatric illness. It's not typical if you want to ask me the question. That's why the diagnosis initially wasn't that. But then again, since the patient has a lot of systemic problems like rhabdomyolysis and fine cracks of the lungs with the positive antibody, so it's more likely now is becoming autoimmune. And the one thing that I'm worried of is initially before the biopsy, before the response to the steroids, is inclusion body myositis. But I know he's still young, but then thank God he responded to steroids, and therefore the myositis is becoming the probable part of the autoimmune part is now more clearer in that sense. So prognosis wise in him, well, the response to steroids means it's working. But then again, because of his psychosocial issues, the recovery is going to be very slow and very challenging. Because number one, the patient is also not really have a good insight regarding the illness, and physiotherapy is of course the one of the modality of recovery. But then again, it is still up to the patient to improve. So if you ask me about prognosis, is quite good in this sense. Now, if you talk about the muscle, but the systemic problem, as long as the kidney is dialyzed, then I'm afraid the prognosis now is not that bright if without the kidney problems. So I suppose that's the issue now.
So kalau monitoring wise, then you monitor basically with autoimmune panel level antibody
and
with CK, is it?
Yes.
Oh, okay, alright. So, okay. Because this patient with a lot of psychosocial issues, then it's a bit difficult also to, you know, for patient to grasp what is his problem is. And then it would definitely influence the recovery status as well, I suppose.
Betul.
There's another question saying the home placement. Family not keen to bring home and thinking of nursing home placement, but financially they are very constrained. So I think that's life. No, if I think they can bring home, right? Yeah, if you don't have money, if you don't, it's simple, you know. If I have no money, I don't go to stay somewhere. So just tell them lah, got money, go to the nursing home lah. If not, just jaga lah. I mean, that's facts of life that we have to tell a lot of people to, you know. Tapi
so Arif, what is the reason of the patient still in the ward now? Because now he doesn't require dialysis anymore, right?
he is. We can do outpatient also. You can do outpatient dialysis.
So what is the reason of keeping in the ward?
And hospital is not hotel, you know.
Prof, Assalamualaikum, Prof. Assalamualaikum, Prof. Actually, this patient, I'm Azhar, I'm from Nephro. Prof, these patients, according to the previous blood, for the past 3 to 4, renal function shows a static creatinine. In fact, most likely this patient will not require any renal replacement therapy anymore. He might have a new baseline as a CKD pending the ultrasound, although we had a CT abdomen prior to that to show nothing significant. However, the reason why this is going on is because we just got the results of the muscle biopsy only recently from the surgery that was performed before. Therefore, we are at the juncture of diagnostic dilemma at that time, and we are in close communications with Prof. Shari as well with regards to the diagnosis. The physiotherapy that we saw and we discussed are still doing an extensive physiotherapy. At this point of time, to sit to the side of the bed require one minimal assistance. However, in terms of mobility and transfer is still yet happening, and it looks like it's going to be a very long recovery. We were just also trying to sort out regards to the steroid, immunosuppressants, and a few other things, Prof. And then we were thinking about initially we were thinking in the line of, like Prof. Tan mentioned earlier, of if do we need to have a fresh muscle biopsy, because from the discussion before, we just worried that the diagnosis of inflammatory myositis might not be 100% definitive without the gold standard muscle biopsy. So I think now the fact that we have got more information and probably with the more serial renal functions, seems like maybe patient might get away without any dialysis, and it will be eventually the renal function might deteriorate, and then we will have to discuss with that regards lah. So maybe we can start planning in terms of getting patient home, and then we'll try to liaise with the family with regards to their planning with regard to Rumah Kebajikan, and they are sending to the Petaling Jaya,
and then the financial, and then hopefully from there, probably patient should be able to go home.
But Prof. Syarif, do we need a repeat muscle biopsy?
From the report, I think we should.
Okay. So in that case, before we discharge the patient, we should plan for a new, a fresh muscle biopsy. And once muscle biopsy done, maybe we can discharge the patient, then we can review the results. In terms of rheumatology, there's no point of keeping the patient in the ward still, right? Yeah, I mean, he will get infection. Is there any reason for us to keep him in the ward now? No.
No. But looking at the where they're going to send dekat Sangriang, Pahang. So I'm not sure how near it is to Kuantan. Kuantan has a rheumatologist, so maybe to consider to refer him there. Unless it is a bit far from Kuantan, nearer to us, then don't mind following him up here.
No, I think the decision will come from the patient family, and it will take long time. It will take long time. They will need to settle this 2 weeks time. They will talk about MCO. They will talk about CMCO of moving state interstate. I think we can give them time to think when the patient at home. You know, it's okay. They can discuss whether to bring. Doesn't mean that if we discharge a patient to home, then they cannot bring the patient to nursing home later, because if not, if we want to wait for them to come a decision whether to bring it to Pahang or Cheras or to other state, the CMCO is still going on, so the center wants a PCR, so it will take long time, and the patient will succumb to a chest infection. He's on steroids. So my suggestion is that I understand the financial issue, but we don't have to wait for a patient to come out, the decision where to send to. We send the patient home first. We send the patient home first. I know it's 16th floor, but he can be wheelchair, kan? Boleh pakai wheelchair, kan?
Prof, he can the transfer to wheelchair. He needs 2 heavy support because of his body size. And it has to be, the problem is we don't have manpower with regard to the family, but we will ask the uncle to actually assist us in support. The uncle, although financially is very tight, but extremely supportive and always be in close contact with us. So maybe we can do something about that. The other thing in Prof. Syarif, the Rumah Kebajikan Warga Emas Sangriang in Pahang was an idea thrown in by the family, because at that point of time we were talking in regards to dialysis dependence. Therefore, that was the only place that they could find where there's a Rumah Kebajikan, and then they can actually arrange to hemodialysis center that was nearby. However, now given the fact that the kidney shows some recovery and doesn't require renal replacement therapy, probably he will be able to find somewhere close by where they live, because no one actually live in Pahang. But then the problem when it comes to close by will be the cost that the family did raise. Unfortunately, I think this is something that the social worker JKSP will help, and then we'll probably liaise with the social, like Suchi or other organizations or social organizations that can assist with the patient. So perhaps sending the patient home and preparing for further placement is an option.